Good morning, everyone. My name is Soumya from University of Texas. I'm going to talk about a case of unfortunate interaction of Impella 5.0 device with mitral valve apparatus. Our case is that of a 61-year-old African-American gentleman with history of non-ischemic cardiomyopathy, ejection fraction of 20%, who presented to the emergency room at an outside hospital with acute decompensated heart failure and atrial fibrillation, which was uncontrolled. He was quickly recognized to be in cardiogenic shock, multi-organ failure. He had severe lactic acidosis with a peak lactate level at 12.8 millimoles per liter. He was emergently taken to the cath lab. An Impella CP was placed. He was started on pressors and eventually stabilized on dopamine and was transferred to our center. Post transfer to our center, we had obtained an initial right heart cath on the Impella and pressors, which showed a cardiac output of 5.2 liters per minute and a cardiac index of 2.4 liters per minute per meter square. The wedge was 16. The PA pressures were elevated, and the PVR was around 5 Wood units. These graphs show the trend of the biochemical parameters after the placement of the device. The red arrow here in all the graphs depict the time at which the Impella CP was placed and the inotrope support was initiated. And as we can see, the lactic acid levels had resolved. The transaminases had come down. Although the total bilirubin levels remain elevated at as high as 30 milligrams per deciliter. Subsequently, the patient had persistent coagulopathy with elevated INRs in 1.92 range, and he had required intermittent blood product transfusions because of bleeding from the insertion sites, etc. Advanced heart failure therapies workup was initiated, and he was deemed not to be a candidate for heart transplant, of course. Neither was he a candidate for durable mechanical circulatory support long-term at this time because of multi-organ failure, severe deconditioning, and this pulmonary hypertension, which needed further workup. The decision at this time was to pursue an attempt at axillary Impella placement in order to buy time to as a bridge to decision making. The goal was to enable him to participate in physical therapy so that he could eventually, hopefully, recover his liver function, and possibly LVAD could be considered as a destination therapy. Unfortunately, he developed some fever and leukocytosis required without a clear source. He was treated with a 10-day course of empiric antibiotics, broad spectrum. Subsequently, he received a 5.0 Impella in the OR under TE and fluoroscopy guidance via the right axillary approach. And this intraoperative TE picture shows the positioning of the Impella. About 14 hours later, the patient developed cardiac arrest from ventricular tachycardia, required CPR for a few minutes, and post-arrest, we can look at the video clips here. The Impella position was appropriate. There was only trace to mild mitral regurgitation. Over the next 48 hours, he continued to remain in shock, requiring higher doses of inotropes with dopamine and vasopressin, in addition to the Impella support he was receiving at a level of P7 with flows of around 4 liters per minute. Epinephrine was added, urgent right heart catheterization was performed, transthoracic echo was performed. The right heart cath showed very low cardiac output and index of 3.4 liters per minute and 1.5 liters per minute per meter square. There was some degree of RV dysfunction here, and the wedge was elevated to 30 millimeters of mercury. The transthoracic echocardiogram revealed acute severe mitral regurgitation, and there was some suggestion here of a restricted mitral valve movement. So the patient at this point was electively intubated for trans-esophageal echocardiogram for further workup, and that revealed a very flail anterior mitral valve leaflet, as you can see here, some degree of RV dysfunction, and the impingement of the Impella pigtail in the mitral valve caudal apparatus, resulting in restricted caudal motion, caudal rupture. These are few more image clips showing the same thing, torrential mitral regurgitation. And unfortunately, the patient was not a candidate for surgical correction at this point, nor was he a candidate for palliative mitral clip placement. And at this point, palliative care team was consulted, several family discussions were held, and patient unfortunately had severe metabolic derangements and succumbed to PA arrest. As we see increasing use of Impella devices for different reasons, we are also seeing increasing number of complications of Impella. The well-known complications are that of aortic valve injury, hemolysis, vascular injury, limb ischemia, etc. But usually mitral valve complications have not been very common. There are very few case reports on literature search. One is that of functional mitral stenosis, which is due to Impella position itself. And there are few case reports that I found on acute mitral regurgitation due to Impella placement, and two of which were due to caudal impingement and caudal rupture, just like our case. And there was one other case because of perforation of anterior mitral leaflet because of the Impella device placement, which needed surgical correction. So in conclusion, although this is a rare complication of use of Impella device, sometimes we need to be vigilant for complications like this, and early detection is crucial.
Thank you very much. It's a case that brings many questions, at least to my mind. So if everything okay, I would like just ask a couple of questions. With respect to, let's start with an axillary thing. It's something that's being very much proposed, the axillary approach, which is nice because it has the availability to make people ambulatory. But that's something, of course, that doesn't happen a lot of times, of course. And you also had some complications with the axillary approach, right? So I think if patients are very ill and you don't have time, then I wonder whether it's not so sexy, but I think the femoral artery is still a very good option, and it's easy, and you really have very little hemorrhagic problems. And with respect to this mitral problems, it's not very much discussed, but it happens. And it's not always just because the pigtail has caught one of the mitral papillary muscles or the chordae. It sometimes also flips the Impella. So you really need. First thing is you really need to make sure that you put it in correctly. I think I know it's a drag. I keep saying this to everybody, but please take some care when you leave the device in at that time. And if you position it, then also make sure that once you put it on, it tends to suck into the ventricle. Then pull it a little bit back to see whether it's okay or not. So just take a little bit more time to prepare the Impella once you set off to the patient to the ICU, because then everything becomes messy. It's more difficult to get people, things going on. Of course, many more questions are there, of course.
So one question would be, this patient initially was put on an Impella on 3 of dopamine, not exactly rocket fuel. So in this sense, when this happened, was there consideration of maybe removing the Impella and then trying a balloon and or a mitral clip? Well, I imagine the mitral program probably wouldn't be too happy. It's technically challenging to catch a flail, but obviously made the decision that you had to make at the time.
I mean, it's true that I did say, for the sake of time, that patient was stabilized on dopamine 3 micrograms. This part of the course was at an outside hospital where the patient had required higher doses of pressors. He had required dobutamine, dopamine, and was eventually stabilized at dopamine 3 mics.
I wanted Jose to teach us a little more because you, at dinner, said the other night, when you turn on the Impella, depending on which Impella, you may see a different course of, you may actually have a different tension and the properties of the catheter such that they may flip more than the others. Do you want to comment on that?
Well, of course, the device is improving all the time. So, I mean, the iteration, let's say, from 10 years ago is not the iteration from now. But the CP is, of course, is a better 2.5. I know this is an exaggeration, but there may be a little bit more energy into the device. So there is a tendency perhaps to be more flipping. So you have to be aware of that. And if it does, then take your time and you have to reposition it. I know it's not nice, but you have to do it. Otherwise, you'll have an Impella which is not working in a ventricle. No, that doesn't help. So it is really about taking the time once you set it in. You don't need to have P8 or P9. It's just not necessary. And it's much more relaxing for the device to move around P7. So it's not that you go to the max, but I think it usually gives a much more stable entity. So don't try to go to higher levels. Just get a stable position and take your time. Just now there was the comment about doing a CP and then wait before you put in an RV. And I am very fond of putting in patients on a CP or 5.0 and then just wait for 10 minutes. I know it seems a huge time. It's just 10 minutes. And it gives you so much understanding about the device. If you pull the device a little bit and you see that the pigtail is opening up, you're entangled. If you put the Impella on and you put the P9, you'll go inwards. And if you reduce it, you go outwards. Take some time. The catheter is just, it also becomes warm. So after some moments, it has tendency to go even further in. Just take a couple of more moments, then just, it's done.
Soumya, what do you think, at what point did this acute MR start? Was it, because the patient had a CP in place, you showed a post-echo after the arrest with it being about 4.8 centimeters inside the LV. Didn't look like there was MR at that point. But then it sounds like after the 5.0 was placed, there was acute MR from possible caudal rupture. So do you think it was during the placement? Was there an issue with cord entanglement at that time?
So the timeline was the patient received Impella CP at the outside hospital, came in, got an echo which did not reveal any significant mitral regurgitation. Eventually, the Impella 5.0 was placed under TE and fluoroscopy guidance in the OR, and I showed the intraoperative picture which showed appropriate position. Post 5.0 placement, about 14 hours later, he developed cardiac arrest. And post-arrest, we also have an echocardiogram showing that there was very trace mitral regurgitation. So I don't think it was an issue of the placement or something that happened during the CPR. I believe something happened between that and over the next 24 hours. So we don't exactly know where. We did look into the nursing documentation and the Impella position, the mark that's visible on the outside, and it didn't seem to change. So not quite sure how it could have interacted with the mitral valve.
And did you, I know it's a crazy idea, but did you actually pull out the Impella and see whether the MR was relieved?
I don't.
Because
Really?
in some cases, what also happens is that the inflow, you really can suck one of the mitral leaflets. It's not that you suck it in the Impella, but you really get a downward pull, and you induce mitral regurgitation. So you can actually then, it's better to just discontinue Impella or put it to P1 or extract it. And I mean, the patient, you said, was about to die. So at least try to pull it to see whether the MR is relieved, and then you have a new situation altogether.
I don't believe we tried that because we could see on the TE image that there was caudal rupture and flail anterior leaflets. So we didn't manipulate with the...
So I have a question for the panelist. When you have a patient on CP and is failing CP therapy and you're upgrading, what is your strategy when you are trying to do when the person is CP supported that interim time when you're trying to pull out and put the new device in, how are you going to bridge these patients?
Yeah, it's a very good question. Usually it's pull and pray. So, yeah, not easy at all. Oftentimes, they usually, if they're failing a CP, usually just add ECMO to it so you don't have that problem. But I've not done CP switching to a 5.0 and somebody that unstable. Have you guys?
I have the excuse that we're just developing our escalation algorithms because I don't know what they do, to be honest. But no, one thing we did do one time with one of our interventional cardiologists, Saif Anwarudin, was to put a balloon pump on the other side. And, basically you're ready with a balloon up while the CP's out. And then I knew Jose was going to say this. But we almost left the balloon, and I said, Saif, please, let's just call Christian and get the 5.0 in, which we put in after that.
I mean, yeah, this is food for thought. Right.
Well, you can take the patient to the OR, cross the LV, get ready with the 5.0, and then it's just going to be a minute, take it out and put the other one in. So,
I agree. I think perhaps, again, do you have a burning question?
Burning comment.
Burning comment, okay.
Burning comment. One, I think the exchange of CP and 5.0, we've done quite a few. It's probably not bad as long as you have good CV anesthesia in the OR, give a bunch of inotropes, and as he commented, you have the wire, it goes in quick. I want to make sure we don't walk away that this is related to all 5.0s and we shouldn't do 5.0s, because I think we've done a lot of 5.0s. The 5.0s are a little more trickier because they come from the right axilla, so their positioning and their ability to flip and torqueability are not that easy. I think in your case, post-CPR is probably where things fell apart, because you could see the Impella more under the mitral valve. Sometimes we minimize taking them, doing a TE and repositioning it. We should just, it's much more burdensome to reposition these, and when it comes out, you can't put it in. But 5.0s have worked really well, but you have to be careful with the nuances, as you pointed out.
Well, I love the 5.0s. They're really stable. You can take them long-term for support. I think the right axillary, I know Abimed has a different opinion, but I think for clinical purposes, left-sided is so much more easy, is really into the direction. You don't put force, double force on the pigtail, on the curved entity. So I think you should at least consider sometimes also a left-sided axillary. With having said that, I think we really need to move on, although it's very interesting. Thank you very much for your